Feeling blue?
Good.
Good.
Good. We are called to create an even better and more just world.
And this is Creighton's response.
Reach out beyond boundaries.
And differences.
To serve those with needs.
Greater than our own.
This is Creighton.
This is Creighton.
This is Creighton in the community.
Hello and welcome to the special edition of Creighton in the Community. My name is Joyce Bunger and I'll be your host. What's your score when it comes to your heart? As we read materials about heart disease, we often talk about that important word, what's your score? I'm here at the Cardiac Center. We will be interviewing three of Creighton's top cardiologists, and with me is Dr. Tom Lanspa. Dr. Lanspa, tell me what it means when to be sure you know what your score is when it comes to your heart.
Well, when talking about your heart and particularly peripheral vascular disease, the score we look at, or what we ask patients to consider, would be basically the classic risk factors, which would be diabetes, hypertension, cholesterol, family history of any vascular disease, things like that, and that would be the main.
And at what point should I start knowing what my score is?
Depends on what your risk factors are. If you're diabetic, then probably by the time you're age 30 or 40, you should be keeping close track of your other risk factors, or specifically if you have family history, parents who have had heart or vascular issues when they were young age, then you should be more in tune with what your risk factors are.
It seems that all too often, people lump the all heart diseases into two words, heart attack. Is there such a thing as a heart attack?
What we usually refer to as heart attack includes several different entities, but usually that's still the public's understanding of when people come in with a closed vessel to their heart. That is what is known as a heart attack.
That's what the heart attack is.
That's what a heart attack is.
I know that you are an expert in peripheral vascular disease and peripheral arterial disease. Tell me about those. Those are kind of scary words to me, so tell me what they mean.
Basically, peripheral arterial disease is the same process. Blockage in the legs mostly is what we consider. Same process that blocks the arteries to the heart that causes a heart attack. So it's the same process, just in different areas of the body. Peripheral arterial disease means blockage of any arteries that does not include the heart. Everything excluding the heart, but any blockage anywhere in the arteries of the body other than the heart.
Am I going to feel that if I have a blockage?
You know, the one thing we stress to patients is very commonly peripheral arterial disease is silent. You can have it and may not necessarily have symptoms, or you can have it and have atypical symptoms, pain in the legs that people do not usually consider secondary to blockage. So it's very common, widespread, underdiagnosed.
Okay, so then I'm going to go back. So that's why it's pretty important to know if you have any risk factors so you can be looking for those signs?
Yes, and the screening test for our peripheral arterial disease, unlike in coronary disease or heart disease, we have to do pretty specialized, expensive tests to pick that up. Peripheral arterial disease, the screening test for that is very simple, called an ABI, or ankle brachial index, and essentially it's just taking blood pressures in the ankles to detect if there's blockage. A very simple test.
So instead of the blood pressure in your arm, it's taken in your ankle?
We actually take it in both arms, both ankles, and then you compare the two. If the pressures are lower in one or both of the legs, then that would indicate blockage in the legs.
Is this something that we should be asking or I should be asking my physician to be doing when I go in for my annual physical?
You know, most primary care physicians probably do not routinely do ABIs. There are some that probably do. It certainly can be done in the office of a primary care physician. Most times, though, if there's a concern, then he will refer them to one of the vascular specialists, either us or a cardiologist or a vascular specialist, to get that test. But it really can be done in the primary care office.
Is this something that you're more inclined to get after the age of 50 or before?
Most people we see it, the older you get, the more likely it occurs, and again, particularly in diabetics. The diabetics are the group of people that we specifically recommend that this be checked in.
When we see the advertisements on TV for the buildup of plaque, is that what we're trying to eliminate, is the plaque in these arteries?
That's basically what causes peripheral arterial disease, is plaque in the arteries.
I'm going to say this again, peripheral vascular disease, or PAD, which is peripheral arterial disease. Are there lifestyle changes that I could do to prevent?
Sure.
I imagine surgery is the ultimate.
Yeah, that's the last
Last
that's
resort.
the last
well,
resort
what are
option.
my steps up to that point to avoid surgery?
You know, in treating any disease, like anything, prevention is always the primary thing we look at. And you're right, prevention is the main treatment for this. In terms of, again, looking at your risk factors, knowing what your cholesterol is. The higher your cholesterol, the more likely you're going to plug the arteries up. And so that's extremely important. And then just lifestyle changes in terms of staying active. When we see people that have even advanced peripheral arterial disease, bad blockage in their legs, the primary therapy for that is just plain and simple walking, exercise, continuing to exercise the legs, and that helps build up the circulation in the legs.
So I was going to say, if the plaque is there, does that just kind of keep the plaque moving around? It improves the circulation?
Improves it when you walk. It improves the circulation of the legs, and it'll help also to build up collaterals or vessels that can go around the blockage that'll help feed the legs. The other very important point we stress on people is stop smoking. If people don't stop smoking, none of these other therapies are really going to be of much benefit in terms of diet, exercise, things like that.
What age does this start?
Starts earlier than most people believe, and most we think now that probably begins even as early as in your early 20s. We found this out in the 1960s in the Vietnam War. When they did autopsies on all these young men coming back from the war, we found our astonishment that that atherosclerosis or blockage in the arteries begins as young as age 20 to 25, which up until that time was kind of, we did not know that, but interesting information.
Which would lead us to believe that it's hereditary, that you're born with it?
A lot of it is heredity, and a lot of it still is factors that we really don't have a good idea, but we do know a strong heredity component to it.
Well, I want to conclude with one last question, but I just think we need to echo what you've said. If you are a candidate or have been diagnosed with PVD or PAD, it's exercise, diet, stop smoking. What else is very important that people should know?
You know, when we see people with peripheral vascular disease, almost always if you have blocked arteries in your legs, you're going to have blocked arteries in your heart too. People don't die from blocked arteries in their legs. What they end up, the mortality issue is the associated blocked arteries they have in their heart. So in people that we know have peripheral vascular disease, the very important thing is to have them come in and be evaluated for coronary disease, specifically to do a stress test, because again, that's where people die from this disease. It's not so much the blocked arteries in the legs, although those can cause symptoms. It's the associated blockage in the arteries to the heart, or strokes, blocked arteries in the carotids that they can get.
Thank you.
So.
And when we come back, we will visit with a physician who specializes in electrophysiology. We are here in the Cardiac Center at Creighton University. I'm joined by Dr. Kelly Airy, and Dr. Airy is fondly referred to as the electrician of the heart. Her specialty is electrophysiology. But Dr. Airy, before we start, tell me about this magnificent room we're in.
Oh, isn't this wonderful? This is where our cardiac rehab patients come and they have their workout. And it's actually open to the public.
Oh, open to the public. I could join.
Absolutely. It's $25 a month, and with that you can see an exercise specialist and a dietitian. And it's open daily from 6:30 until 5 o'clock. And you can see that they have a whole bunch of equipment. And
we should also mention why there's no one on the equipment is it's quite early when we're doing this interview, but normally this place is a buzz. Well, let's go back to being the electrician of the heart. Tell me what that means.
Well, the electrical system of the heart controls your heartbeat. So everything starts with an electrical impulse. And that is where we come in. So we help restore the electrical activity with pacemakers. People that have abnormal rhythms, we perform ablations on. And people that have abnormal life-threatening rhythms, we put in defibrillators. And then there's a special class of people with heart failure that we put a specialized pacemaker in that pumps both sides of the heart simultaneously.
When I was doing some research on you, I noticed that you spent 10 years in private practice before going into this specialty. Tell us a little bit about why this area fascinated you and why you strove towards it.
Well, when I was in medical school, I always enjoyed cardiology, but I just wasn't quite sure that I was ready to make that commitment. So I did family practice, general practice for 10 years prior, 5 years in Canada, and then 5 years actually very close by in Missouri Valley. And then it was after 10 years of practice that I realized, yes, I do want to dedicate myself to cardiology. So I came back to University of Nebraska and did a fellowship in cardiology after internal medicine. And then I went on further and did electrophysiology fellowship.
Now, in an earlier segment, we talked with Dr. Lanspa, and we talked in terms about a heart attack. We talked about the vascular system. When does a cardiac patient see you? What leads up to a visit with you?
Well, usually, as we have been talking about, when there's failure of the electrical system. So if people have abnormal heartbeats or their heartbeats are too slow and they need help with a pacemaker, they're passing out because their heart's not pumping enough, or if it's pumping too fast and they're having what we call ventricular arrhythmias and need a defibrillator, that's when they come to see us. Now, the other group of patients, as I mentioned, are those people with abnormal rhythms that we can go in and treat permanently with catheter ablation.
Now, I'm going to back up the train even farther. How do you get to that point to even know that you have an irregular heartbeat? How would I know if I have this?
Well, usually you can feel it. You can feel your heart pumping very quickly and intensely, and it's what we call palpitations, where you just feel like your heart's skipping or it's going to bounce out of your chest. And normally, in that situation, you'll go see your doctor, and your doctor will do an EKG, or if it's not readily apparent at that visit, they will set you up with a test where you wear a monitor for a number of days, and if it gets picked up, then you'll get sent to us.
Many of our viewers are just going to be people like me, and so we hear the term called, oh, it's just a racing heart. How do I know that my racing heart is more serious than just being terribly excited?
Well, that's when the Holter monitoring comes in, or the event monitoring. So that's when you go see your physician, and they can hook you up with electrodes and a little monitor that you wear that records your heartbeat either all the time or when you have symptoms, or when it detects an abnormality like your heart's too slow or too fast. It will automatically record, or else you push a button when you're not feeling well, and then we can see if the symptoms you're having actually correlate with any significant arrhythmia. Those get transmitted to cardiologists to read and then go back to your family doctor, and if there's anything concerning, then they will set you up to see an electrophysiologist.
Are you ever at a point, is someone ever at a point that they can avoid coming to you? There's lifestyle changes?
Once you have an arrhythmia that needs treatment, there's typically not many lifestyle changes that are going to change that.
Now, my mother had a pacemaker put in when she was in her late 80s. Is that generally when people get pacemakers, or can you get a pacemaker in your 30s or 40s?
Usually, if you're getting a pacemaker in your 30s or 40s, you are born with some sort of abnormality in your heart, what we call congenital abnormality. As you get older, just like a lot of other things, your electrical system starts to wear down, and your sinus node starts to beat more slowly, and the conduction slows in your heart, and you need a pacemaker. So it's all part of the aging process. So we typically put more pacemakers in older people.
And let's talk about these terms for a minute. You talked about, and I want to get this right, atrial fibrillation ablation. What do those three terms mean? We read about them very casually in advertising and in newspaper articles. What do they mean?
Well, atrial fibrillation is the most common arrhythmia that we see, and it's actually more prominent in elderly people. Once again, as you get older, you're more likely to have atrial fibrillation, and that's when the top part of your heart beats very, very rapidly and out of control. I mean, sometimes 350, 400 times a minute. And that conducts down to the ventricle, to the pumping chamber, but not every beat does, just erratically. So you get a very irregular, fast heartbeat, typically with atrial fibrillation. And in the past, we had treated it with drugs and not really even treated it at all. And now we have a very effective ablative procedure, invasive treatment for atrial fibrillation, where we can actually go in with the catheters and burn some of those abnormal pathways. And that's becoming more and more prevalent to do that procedure.
So the other option for that was putting some device in that regulates the heart?
No. Up until the ablative procedure, the way we treated atrial fibrillation was usually with medication and then keeping your blood thin, because atrial fibrillation increases your risk of stroke. The device that you're thinking of treats ventricular arrhythmias, ventricular tachycardia, not atrial fibrillation. Until now, there's been no effective implantable devices that treat atrial fibrillation.
I said this earlier with Dr. Lanspa, and I said it with you, is that, we used to say a heart attack. And I think what this show is going to demonstrate to our viewer is there are many, many components that all go together to support your cardiac care.
Absolutely.
I have one last question for you. I understand you're very active in renovating the new suite, the cardiac suite in the hospital. What are some things we're going to see in that suite that aren't there now?
Right. Well, as you can see, electrophysiology is emerging in the cardiac field, and Creighton is now building us our own electrophysiology lab or operating room, and it's under renovation right now, and they've actually spent about $1.2 million, and we're getting all state-of-the-art equipment, and they've hired a couple of people who are trained in complex ablative procedures to do these procedures on people that we've been talking about, the atrial fibrillation ablations. And
so Creighton's going to be the place to be.
Absolutely.
Absolutely. And when we come back, it's all about me. We're going to talk about women and heart disease. We're still at the Cardiac Center at Creighton University, and I'm here with Dr. Tracy Jurens. Her specialty is primary women's heart. And a woman today can't help but pick up a magazine and see advertisements about women's heart issues. And we're going to learn today why women need to be particularly in tune with what's going on in heart disease. Dr. Jurens, I'd first like to point out the ad. It says, "Put your heart in their hands," and I'm noticing that all of the cardiologists, including yourself, are women. Is there a message that you want here, that women caring for women?
Absolutely. I think that some women certainly feel more comfortable having a female doctor, and I think a lot of women tend to be concerned about their heart and would be more open to see a female doctor.
I think, tell me if I'm wrong, is that women are 10 times more likely to have heart disease than men. Why is that?
Well, I think that they're more likely to have a more serious event, and that'd be a few reasons why. Number one is I think a lot of women feel that heart disease only affects men. And in fact, there's been a survey that shows women who answered this survey, just over 50% realize that cardiovascular disease is the #1 cause of death in women. And in the same women population, less than 15% were concerned that they may have a risk factors for heart disease. So I think that women tend to ignore some of the symptoms of heart disease because they think, well, it can't happen to me.
Like, what are some of those symptoms?
Well, some of the symptoms classically would be chest pain or pressure in the chest that may radiate down your left arm or up your jaw. Could be shortness of breath, swelling in the ankles, difficulty breathing, especially with exertion, sometimes difficulty breathing in the middle of the night. And for women, oftentimes they present with the more atypical symptoms, not the chest pain, but more the shortness of breath, and they may think, well, it can't be my heart, I'm a female.
I think you're right about that. At what point should women start being concerned about their heart? Now, I'm going to preface this by saying when we talked with Dr. Lanspa, he talked about knowing your score.
Sure.
And so let's talk about that for women. When should a woman be, at her annual physical, be paying more attention to those scores?
Well, I think number one, it depends on your family history. So if you have a family history where of people having heart disease at a young age, then you start worrying about 10 years sooner than the person in your family that had heart disease. And specifically, I think women, when we start getting above 40, should start worrying about getting checked for high blood pressure, cholesterol. Certainly we should think of not smoking ever, but if you do smoke, to consider getting help with quitting. And then, but all our life, no matter what age we are, we should try to be as active as we can and, limit our risk factors, eating the right types of foods.
One of the things that I'd like to just go over again, and this is somewhat repetitive, but when people hear heart disease, what are some of the words, diseases? Like, for instance, what's coming to your mind? Stroke. What are various heart diseases that women need to look for? What are key words?
So heart attack.
Heart attack.
So, or what we call myocardial infarction. Heart failure. So that would be swelling in the ankles, shortness of breath when they wake up in the middle of the night, and even some valvular diseases that aren't as well known.
Because I think that is the part that really worries me the most, is I think, okay, I have some of these things, so when do I see help? And let me ask another question. If I start feeling some of these symptoms, at what point do you see a primary care physician, and at what point do I come to see you?
Well, I think the primary care physician is one of the earliest physicians you should see, and they should have a judgment on whether or not you should be seen by a specialist. And however, it's not unusual to come straight to a cardiologist if you're concerned. And we're always happy to see someone if they're feeling like they're having symptoms of heart disease. We just want someone to be seen.
We talked earlier before the interview that screenings are important. So if people see that there is a health fair or free screenings, they should take advantage of those.
Absolutely, because it gives you an idea of where you stand, and it's primary prevention. Basically, what we want is to take care of those risk factors early so you never have trouble in the future.
Let's say that I want to make some lifestyle changes right now. What are the most important lifestyle changes? You mentioned smoking, and I think we should also mention that the Cardiac Center also has smoking cessation classes here.
That's right.
So what are some of the things that, we have our treadmill behind us, the people on treadmill, what are some things that I can be doing right now? We've talked about the screening to find out if I'm at risk. We've talked about stopping smoking.
I think having a good diet is a good start. So limiting your fat intakes and the sweets and eating more fruits and vegetables, that'll help with the cholesterol and your overall health. And then an exercise program is a wonderful way to start as well. Start slow and then work your way up. There are personal trainers out there. There's even here we have trainers who can help.
We hear a lot too about body mass index.
Yes.
And the one I heard this weekend was that about the central. Could you talk about that a little bit?
Well, there has been some association of the central obesity with certain risk factors, including high triglycerides and diabetes. And so the association is there, and of course those can lead to heart disease. And then body mass index in general basically takes into account your weight for your height. And there are certain areas where we'd like you to be in, and I think diet and exercise can help get you into that area that is your goal.
I'm noticing that there are 7 cardiologists in that picture. Are they all have similar practices?
Each of us have our own subspecialty in cardiology.
Such as?
Well, for instance, mine is valvular heart disease.
Well, we did just earlier talk to Dr. Lanspa, who works in the peripheral areas, and then we talked to Dr. Airy, who refers to herself as the electrician. What are you in the heart?
Well, with valvular heart disease, we're looking at one of the 4 valves of the heart. And valvular heart disease means one of them isn't working appropriately. That's either the aortic valve, the mitral valve, or the pulmonic valve, or the tricuspid valve.
And what causes them not to work?
Well, it depends. There's various reasons why they may not work. It could be something they were born with, such as a bicuspid aortic valve. Normally the aortic valve has 3 leaves, but a bicuspid valve has 2 leaves, and that can cause problems in the future with these people.
Born with it?
Born with it.
Okay.
But oftentimes we find people with valvular heart disease that acquire it over their lifetimes. And it could mean that the valve is incompetent and it leaks, or it could be that the valve is narrowed and cannot get the blood out. And we follow this usually with an echocardiogram, and occasionally it means that the valve has to come out or be repaired.
And how would I know if I had this problem?
Most people who find out they have this problem is a murmur that's heard by their primary care physician, and they get sent and then usually get evaluated with an echocardiogram.
And then you have time to repair it.
Usually you have time to repair. Occasionally people come in very late with symptoms, and those symptoms could be heart failure, such as swelling in the ankles, or problems breathing. And most of the times we're able to repair those or replace those valves.
And I'd like to conclude with one last question for you. And let's just recap after all the shows. What are the primary messages that we should take away from this show? And let's particularly for women. What are some messages that we need to remember?
I think we need to remember that heart disease is the #1 killer for women, and that we should not ignore any symptoms, and that we should certainly get our risk factors checked. Make sure we know what our blood pressure is, what our cholesterol is, and then try to make ourselves as best as shape as we can be with diet and exercise.
Thank you.
Thank you.
What's your score? Make a promise to yourself to find out what your score is when it comes to cardiac care. On behalf of all of us at Creighton, thanks for watching.